Hi, and welcome to ADAA's two-part special webinar series, Mental Health on the Front Lines of COVID-19. I'm Barbara Kamholz. I'm a Senior Advisor for Professional Education for ADAA and also a clinical psychologist. And I am thrilled to introduce Dr. Sheila Rausch. She's known to many of you for being a board member here at ADAA and also on the Scientific Council. She is also a fellow of the ABCT, the Association for Behavioral and Cognitive Therapies. When she's not doing that, she's a professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine, deputy director at Emory Healthcare Veterans Program, and Director of Mental Health Research and Program Evaluation at VA Atlanta Healthcare System. She's been an expert in PTSD and anxiety for over 20 years. So welcome, Sheila. Thank you so much for doing this, and on very short notice as well, I might add.
Thank you. Thank you very much for inviting me. I'm happy to be here. Good morning, I guess good afternoon, because this could be watched at any time of day. Thank you for inviting me. I'm happy to be here.
Thanks. So what we wanted to do today was have a very informal conversation about helping, supporting our frontline medical professionals in the midst of this pandemic. Obviously, a lot of organizations and clinicians are interested in assisting our frontline medical providers, which is wonderful. But of course, like all things, there can be a downside. Sometimes incredibly well-intentioned folks may be doing things that seem like common sense, but may not be the best option in the midst of a situation like this. And so we were going to just talk with you, Sheila, about some general guidelines for how to help support and provide some coping skills and coping augmentation for medical professionals on the front line of the crisis. So to start out, obviously just to provide a little context, frontline medical professionals are working with dangerously ill patients. We're seeing, unfortunately, high rates of death by virtue of the sheer scope of the COVID-19 pandemic. And of course, the medical professionals themselves are vulnerable to illness because of the relatively easy transmission of COVID-19. What range of emotional responses would you consider to be normal for medical professionals under these kinds of conditions?
Yeah, so the current COVID-19 pandemic is unprecedented in reach around the world and in the extended nature of this invisible threat. No one, healthcare workers are impacted, but no one is really left without impact, whether it's a direct impact on their health or their employment, or indirect impacts through availability of services and changes in our lives while we're asked to physically distance, and impact on loved ones. So none of this is normal, but emotional reactions to abnormal situations like this are normal. So we need to be ready for our healthcare workers to have reactions, all kinds of emotional reactions. So that's the first thing, is just be ready. Many are predicting that the mental health fallout is going to be grim. And I would agree that we need to be ready for that mental health impact that's going to be significant. But I also feel confident that for most people, this will be a significant event that they'll deal with in real time in their life, and eventually that they're going to naturally recover and move on to a new normal and a satisfying life. I think we need to be cautious in our response as mental health professionals and start with an expectation that people are going to recover and get better, and that we're there to help them with accessing resources so that they can do that. So while we're planning to address the mental health impact that's going to arise, I think we need to also be projecting hope and confidence that for most people, this will be distressing, but they're going to recover with time. Another really important thing for us to remember is that there's going to be lots of varied emotional reactions to this situation, depending on the specific experiences that each healthcare worker or other person that's impacted by COVID-19 might have. And that includes negative emotions that lots of people are talking about, but it might also include positive emotions. There are going to be people that feel a sense of accomplishment and a sense of joy and teamwork of getting through this and dealing with this and helping people, saving people's lives, reducing the impact on communities. So there's going to be anger, sadness, grief, betrayal, feelings of isolation and guilt. There's going to be all of that negative stuff, but in addition, there's going to be a lot of people who have a mix or who have positive emotions as well, a sense of joy when their loved ones survive, and all of those things. So we need to be ready and really consider what are the specifics of what's happened to this individual, and help people to know that their reactions are normal based on their experiences, that it tends to come out that the more people feel like they have a sense of control over the situations that they experience, they're going to be able to recover more quickly. And also if they're feeling supported and cared for over time, that's going to make a big difference in how long those negative reactions stick around for people.
So it sounds like a fairly wide range of reactions, all of which would fall within the realm of normal.
Yes, yes. It all depends on what they're experiencing.
Absolutely. And so what about trauma reactions? What about more difficult reactions? And even in the face of trauma reactions, among medical professionals on the front lines, what might you expect to see in terms of a course of recovery?
Yeah. So again, I've said it a couple times. Most people, if we give them time, they're going to get better. And we need to make sure that they have whatever resources to recover and a sense of control to be able to recover. And again, it's going to depend on the person, how long that takes. For most people, we're still in the middle of this situation, and it's going to continue for a couple more months in most areas. So that's going to extend that period of time. That might also lead to more people having a sense of exhaustion, and feeling like they run out of resources over time. So we need to be ready for that as well, that people who are continuing to work in the healthcare patient care wards now and 2 months from now, that they may actually need a little bit more off time to be at their normal. But we would expect within a couple of months of the end of the acute situation that most people are going to be getting back on their feet and recovering and finding their new normal. And that's going to be especially true if those are people who have resources, so they still have jobs, they still have a place to live, they have connections to their family, and that they also feel a sense of social support. So for people who are able to talk one-on-one to their friends and family about things that have happened to them and get that emotional support, those people are probably going to be doing relatively okay. Still sad because it's a horribly sad situation that we're all living through, but probably able to have a different perspective and move on. One thing that's important with trauma reactions or with any reaction to a difficult situation is, as mental health professionals and as loved ones of people who are stressed, we don't need to push them to do anything for them to naturally recover. We really just need to be there, to be present with them, and for them to have a resource to bounce ideas off of, to talk with you as they see fit, as they feel ready. And projecting hope and confidence in their ability to recover and in your willingness to be there to support them.
So you mentioned things that we could be doing or maybe should be doing to help folks either just process normal reactions or even provide support in times of more significant trauma reactions. For decades, critical incident stress debriefing, CISD, or critical incident stress management, CISM, was recommended to address trauma responses. Is that approach still recommended, and what do we know about its efficacy?
Yeah, so over about the last 5 or 6 years, that approach has fallen out of favor, and it's largely based on the VA, DoD, and other clinical practice guidelines that are based on lots of research that's been done, suggesting that critical incident stress debriefing or critical incident stress management seem to actually increase some of the symptoms of PTSD and distress in some studies that have been done. So we're actually concerned that this type of group debriefing intervention, where people are telling the details of their trauma in a group setting, may actually not be good for people to do in general. So that's really fallen out of favor as a prevention strategy for following trauma.
And it sounds, you reference groups, obviously a lot of people who are very interested in helping our frontline medical professionals maybe thinking about doing support groups, or other group-based interventions. What would your comments on that be? What would your advice be there?
Yeah, so groups can be useful. The thing that we think from research is really important to remember is that we don't want to have groups where people are compelled to tell their stories or have the details of their trauma exposed in a group. So if you're doing a group on mindfulness, just general mindfulness, general stress management, a yoga group, those kinds of things are good. And people, they're nice for stress management generally, including stress management when you're under a stressful experience. But what we would not recommend would be group-based interventions where people are telling the details of their trauma together in a group, because that's what we think may actually be more stressful for some people in the group who may have a different perspective on that same experience. And it's distressing then in the group to feel like your perspective may not be respected as much as this other person's perspective, or your details are slightly different and the ones that you hear someone else say are actually more upsetting to you than the ones that you had in your head already. So we think generally, if you're doing trauma processing where people are talking about specific details of their traumatic experiences, that's best done one-on-one.
Okay. And so what about psychological first aid? Many trauma experts are advocating for that as an intervention in the immediate aftermath of trauma. Can you talk about that, the efficacy of psychological first aid?
Yeah. So psychological first aid has had not a lot of research on it. So it's an evidence-informed intervention. It was created based on a large knowledge base that we have about how people respond to trauma over time. So it's evidence-informed, but the studies that have been done specifically with psychological first aid have been few, and they've generally suggested that it doesn't harm. So it's not like the critical incident stress debriefing. It doesn't harm, but it also doesn't seem to reduce rates of PTSD over time as compared to watchful waiting or other things. However, psychological first aid does provide a lot of really well organized resources in a specific format. So in that way, it can be an efficient way to get a lot of evidence-informed trauma information out to a community. The National Center for PTSD recently, actually, I just noticed it this weekend, came out with what's called COVID Coach, which is a really neat free app developed by our tax dollars from the National Center for PTSD. And it has a lot of those psychological first aid resources right in that app. So people can download the app and look through lots of different resources to see if there's anything that's going to meet their needs in that moment. So in that way, in that format, that COVID Coach can actually be a really useful tool for self-management of trauma response for healthcare workers or for, so-and-so sitting on their couch at home.
Absolutely. Absolutely. That's terrific. Thank you.
Mm-hmm.
So if we were to go through almost like a do's and don'ts list for any of us, really, as we're trying to help loved ones through this if they're on the front lines, but certainly in our professional roles, wanting to support frontline medical providers in the midst of this, what would your sort of best of be? What are the most important things mental health professionals can do for frontline medical professionals? And what should we really avoid doing? I mean, you've referenced obviously a couple of times asking people to really rehash details. What else would you add to that in terms of do's and don'ts?
Yeah. So do's, I would start with the most important thing that anyone, mental health or otherwise, can do for healthcare workers right now is ensure that their basic needs are met. Kind of that Maslow's hierarchy that we as psychologists talk about. We want to make sure that they're being safe, that they have personal protective equipment that they feel comfortable wearing. So that's something mental health professionals can do, is help people desensitize to PPE if they're feeling uncomfortable in that. We want to make sure that they're getting sleep and food and lodging, their basic needs are met. Then we can move on to helpful coping. So talking with people about what has worked for you in the past. Is that talking with friends? Is that exercising? Is it yoga or prayer? And make sure that we're encouraging them to continue doing those things that generally work for them for stress management, even in these difficult times. Finding ways to be able to do that if physical distancing makes some of their normal coping not available right now. How can we find alternate coping? And then we also want to monitor the unhelpful coping. So if people are drinking alcohol more or using drugs or other harmful strategies, we want to also talk with them about reducing that in this time of stress. And then the last piece is really thinking through all of their coping resources. So outside of themselves and the things that we do for ourselves, who are their resources? Who are their go-to people? And go-to organizations, whatever they generally use for coping. And are they accessing those things? How can we make sure that they continue to access those things over time? Finally, for healthcare workers, one thing I'm really worried about is making sure that people are taking breaks because even the best nurse or doctor that's working in an ICU unit is going to need to take a break. Even if there are more and more patients coming in, if they're not taking a break to recharge, they're not going to be able to provide the best care for that patient. They're also not going to be able to take care of themselves. So we need to make sure that that's built into any system, that they're required and that they're able to take those breaks and sign off and stay connected with others while they're working potentially long hours. Lots of healthcare workers are staying away from their families because of the risk of exposure to those family members. So making sure they're still finding ways to stay connected with their loved ones so they know what's going on and don't feel isolated while they're in the stressful situation. And then the last piece is really making sure we're not over pathologizing their normal reactions and putting labels on people or mental health problems or you have anxiety because of COVID. All of us generally have responses to stressful situations. And it's only a problem if it's interfering with us getting the things done that we need to get done. And right now, we're all kind of in these stressful situations where that's going to be the case. So we need to be kind and compassionate with each other and really provide as much support as we can.
So, I'm sorry.
Go ahead.
So in terms of going back to what I'm taking away as your two big don'ts, number one, don't pathologize. This is, I think we all need to retire the word unprecedented at some point, but here we are, and we are in this unprecedented situation. And so we talked earlier, there's going to be a huge range of positive and more difficult emotions, even perhaps somewhat prolonged, unpleasant or difficult emotions. That makes sense. This is a dramatic stressor of immense scope and magnitude. So we don't want to be pathologizing reactions to that. And then secondly, the point you made earlier in our conversation, we don't want to be asking people to rehash their trauma or their traumatic exposure in a group setting for a variety of reasons. That is something that if and when it is to be done, should certainly be done on an individual basis.
Right. Yeah, I like to say we want to avoid compelling people to tell their stories, but let them share as they're ready and willing, and be ready to listen when they do decide to share, but don't force the story.
Great. One thing you mentioned at the top of your list of do's was this idea of PPE, personal protective equipment. And of course, we know we've all seen the stories. We've seen pictures of nurses wearing garbage bags in this country, et cetera. There may be situations in which our medical professionals, our medical colleagues actually don't have the PPE that either would be ideal or they really feel is appropriate per a whole range of guidelines. Any advice on how to help our colleagues cope with that?
Yeah, that's a tough one because we're basically asking them to go into, it's similar to what we ask our military professionals to do, is go into a dangerous situation that we know is dangerous. Sometimes we send them in without the right equipment too, if we remember from these wars early on.
Yeah.
So again, I would say being there to listen, giving as much as we can for what they need, helping them feel as safe as they possibly can within the situation, controlling again as much as we can, but then realizing there's a certain point where we may not be able to control the risk, and then making sure that we can protect their loved ones if we can't necessarily protect them. So are there ways to make sure that they have a safe place to stay if they can't go home because they feel like they've been exposed to a higher level of risk than they're comfortable with being with their family, and those sorts of things. But the best thing we can do is send all of our PPE to those places that need it, and make sure that we're all being responsible as a community in giving the people who are in the most need, the healthcare workers, what they need, and kind of hanging back for the rest of us with lower risk.
So to wrap up today, you and your colleagues, Drs. Barbara Rothbaum and Naomi Simon, are developing a mental health framework for working with COVID-19. What can you tell us about it?
Yeah, so we're developing a framework that's based on lots of past research and also based on some really great qualitative work that's come out recently, including Shanna Felt and colleagues recently published some work with COVID-19 healthcare workers about what they felt like they needed. So it's really looking at providing a framework for healthcare system response over the long haul that's focused on resource allocation and planning for each of those next phases that are going to come, and how can our health systems address those needs that are there now, as well as what's going to be there in a few months and a few months farther along. So.
Well, we'll stay tuned for that. In some ways, quite literally, I do want to mention that Dr. Sheila Rausch, Barbara Rothbaum, and Naomi Simon have graciously agreed to present more of the details on their framework in what will be the second of this two-part special series from ADAA on addressing the COVID crisis for our medical professionals. So we're looking forward to that, and I do want to thank you for being here with us today and for your anticipated presentation then. And please stay well, and thank you again.
Thank you. Thank you.